nursing, OR specific stuff, and particularly, I just want to ask anybody if people can mute if they can, and for attending fellows, residents, advanced practice providers, nurses, physical therapists, respiratory therapists, anybody really that has an interest in treating neurotrauma patients. We are working on getting CME credit through Mount Sinai for this conference, and so hopefully by the next one we'll have that up and approved and you'll be able to claim that CME. I think we'll probably have it set up so that we could register for the conference to make it easy so that it will just automatically go to your Mount Sinai CME. And we are going to be recording these lectures. They'll be available following the lecture online. I'll let everybody know when via email when they're uploaded, but we'll probably be putting them either on Dropbox or Google Drive or both. And we'll email the link to everybody on the list. If you want to be added to our email list or people that would like to be added specifically, just let one of us know. So the first speaker, our Dr. Margetis has graciously offered to be our guinea pig for our first neurotrauma conference. Many of you know him well. He's assistant professor of neurosurgery at the Icahn School of Medicine at Mount Sinai. He's chief of neurosurgery at Mount Sinai Morningside and the former associate director of neurosurgery at Elmhurst Hospital Center. He's also the director of spine at Mount Sinai downtown Union Square. As many of you know, he's done multiple fellowships, both in complex spine surgery at the Cleveland Clinic, as well as in pediatric neurosurgery at Cornell. He's from Greece, and where he got both his medical degree and his PhD. What many of you may not know is that he was also a paratrooper. So, it takes a special person that's willing to jump out of a perfectly good airplane. I believe he did a few surgeries on the way down and landed safely. So he's going to speak to us today about spinal cord injury and management principles. And so I will turn over screen sharing to Dr. Margetis at this point.
Thank you, Dr. Icahn, for the very kind words, and thank you everybody for attending this conference. It's our first one, and if you have any suggestions about how we can improve, please let us know after the conference. Okay. Let's say I can start sharing my screen. Is it sharing?
I'm coming, I'm sorry.
Okay.
I don't know why it's not sharing. I apologize.
Oh, okay. Okay, very good. All right. So we're gonna start with a case example of spinal cord injury. So. So this is a lady that she fell from 5 feet high, and in the emergency department she only had some movement in the biceps and deltoids, but nothing in the legs, and there was no rectal tone on the digital rectal examination. And the imaging studies, the CT scan that the ED obtained, so these jammed facets. You can see here how the facet joints are aligned, but over here this bone should have been over that bone, so there was a dislocation of the spine, and you can see it here, the mid-sagittal view, how that bone has dislocated, and this is the other side. So we try to do a close reduction on that patient, so you can see here the dislocation over here, and in this x-ray we are applying traction to the head, and we're trying to reduce that dislocation. We're trying to bring that bone over this bone here, but it was impossible. So we had to take her to the OR. In the OR, we did a posterior open reduction, and we also did a decompression, because as you can see here on the postoperative MRI, the spinal cord is significantly swollen in that area of the injury. Look here, the normal spinal cord, and here how it has how edematous it is. So that's just a typical case of spinal cord injury. And this is a simple, let's say, spinal cord injury because we're dealing with only an isolated spine injury, which is not usually the case. And that will take us to the first question. And we're going to do a poll question. And so what do you think is the percentage of patients who have an additional spine fracture? Is it 1%, 10%, 50%? I'm going to wait a few seconds for the answers to come in. Okay, so actually the correct answer is 10%, and that's just to remind us that when we're evaluating the patient, that spine injuries are not usually isolated. That's more like the exception to the rule. Usually they are associated with other injuries or with additional spinal fractures or injuries. So another question now. So what do you think is the percentage of patients who might experience deterioration, neurological deterioration after their arrival to the emergency department? Is it 0, 1, 5, or 50%? Gonna wait a few seconds. So it's actually 5%, and this slide here about the pathophysiology of spinal cord injury will explain why. So when a patient suffers a spinal cord injury, we have the primary injury that happens at the moment of the accident, and it has to do with either a stretching or shear of the spinal cord or some kind of contusion, laceration. So that's the injury that happens at the moment of the injury, at the moment of the accident. But after that, there is additional injury that happens to the spinal cord. It's a similar principle to the secondary injury for traumatic brain injury. And there are a couple of mechanisms that, unfortunately, they're active and they cause additional damage. The most important is the edema on the spinal cord and the ischemia of the spinal cord, and that applies for the acute phase. For the subacute and more chronic phase, we have some additional factors like the apoptosis of the neural cells, and some additional mechanisms, with probably more important the gliosis that happens in the area. But for the spine, we have one additional injury mechanism, the repeated primary injury. So, if a patient suffered spinal cord injury, he is at risk for getting more injury if he has an unstable spinal fracture or unstable spinal dislocation. And we need to remember that the external mobilization with braces or collars or longboards doesn't offer like a very rigid mobilization. And especially when we are dealing with ongoing spinal cord compression, even some micro movements during the regular care of the patient can be serious enough, can cause additional damage to the spinal cord. So we need to be aware of that, and that's why we're taking the spinal precautions. But even with all these precautions, there is still a risk for further neurological deterioration of the patient after he reaches medical care. So now let's see some principles for the spine mobilization. So we need to mobilize the spine on non-trauma patients that they have a spine injury or the mechanism of their accident is suspicious for causing spinal injury. We also need to mobilize the spine for patients who cannot communicate. An important point is that if we're dealing with penetrating trauma, there is no need to mobilize the spine. Either stab wounds or gunshot wounds with civilian weapons are very, very unlikely to cause spinal instability. And placing, for example, a brace on a patient who has a stab wound might not allow us to recognize early a hematoma that might develop. So for these cases, we don't recommend spine mobilization. And so the spine mobilization can be done with the cervical brace. We can also put some tape or straps on the head and the rest of the body to mobilize the patient. That's more important when we're transferring the patient or when the patient gets into the ambulance to come to the hospital. And we need to remember that the spine boards, which are still used in some systems, They are very, very, helpful for the transfer of the patient, but they are associated with pressure ulcers, and even within 2 hours, we've seen pressure ulcers develop in these patients. So we need to take them off the long boards as soon as they arrive in the emergency department. And any movement of the patient, if we need to roll him on the side, we use the log roll technique, which is displayed here. You see there are 3 clinicians. One is controlling the head, one is controlling the chest and the pelvis, and the third person controls the legs and the pelvis. And you see how they cross their arms here. That helps with coordinating the turning movements a little bit more. So let's go now to the question to see who is paying attention. Which one is the correct statement? The backboards will be used only for the patient transfer, or we should keep the patients in the backboards for forever? Yeah, that's an easy one. Huh? Yeah, just to emphasize that there are still some instances that they use the backboards, and especially for people who are not familiar with the treatment of spinal cord injury, they are sometimes overzealous and they say, oh, keep the patient on the backboard, and that's not really ideal, okay? So some important points that in elderly people, they might have this cervicothoracic kyphosis that you can see over here. And if we place them on a backboard, or if we place them on a flat stretcher, that's not really ideal for them. So we need to be aware that in elderly people, they might have this kyphosis in their necks, and we need to support the head with folded blankets. So that's important. And the opposite applies for kids. The kids have a big head in relation to their torso, to the trunk. So if we put them on a flat surface, actually we induce flexion of the neck. So what we need to do ideally is either create some kind of recess under the head, or put some additional support under their body so that the cervical spine remains aligned. That's usually for kids younger than 12 years of age, and it's even more important for under 8 years of age, and we'll see why. So let's go now to another question. We have a 50-year-old man had an accident with his motorcycle. He landed on his back. Saturation is fine, respiratory rate is fine. His heart rate is fine, 77, but he is hypotensive. He remains fully conscious, but he complains that he cannot move his legs. So there is obviously some kind of shock because he's hypotensive. And what do you think is the most likely type of shock that he has? He might have more than one, but I think that one of them is pretty, what is the most likely to have?
They're answering. Mm-hmm. They are answering.
Okay.
I just can't see it. Yeah.
Okay, so we'll see that the correct answer is neurogenic shock, because we see that the patient is hypotensive, but he cannot increase his heart rate to compensate for the hypotension. And that's a sign of neurogenic shock. He might have a concomitant hypovolemic shock, but the fact that his heart rate cannot increase, and he's not on any beta blockers, that suggests that there is some kind of neurogenic shock. Spinal shock, sometimes people confuse these two terms. Spinal shock has to do with the loss of muscle tone after spinal cord injury. It doesn't really apply to the hypotension, and although we call it shock, it's not. It's about a shock to the spinal cord, the fact that it doesn't function well. It doesn't apply to the systemic hypotension. That the term shock, defines these other terms here. So let's see a few things about neurogenic shock, because it's very, very common in spinal cord injury. So the neurogenic shock has to do with the impairment of the sympathetic outflow from the central nervous system. So we have a loss of the vasomotor tone and of the sympathetic innervation to the heart. It's very rare to happen below T6 because most of the nerves that go to the heart arise above T6. And it presents with hypotension, and usually there is bradycardia, but remember that the patient might have normal heart rate, but in the presence of hypotension, that's also a sign of neurogenic shock, because we expect compensatory tachycardia in the presence of hypotension, which due to the impaired innervation to the heart that doesn't happen on a patient with neurogenic shock. The treatment is not fluid resuscitation. That's also a kind of common mistake. They think that the patient doesn't have volume and they give a lot of blood transfusion or crystalloids. That's not ideal. I mean, the patient might need the standard infusion of crystalloids, but that will not really treat the neurogenic shock, and actually it can cause additional problems. The treatment is we use vasopressors, and if we have any significant atropine, we use atropine or some other agents to reverse the bradycardia. In terms of the selection of vasopressors, that's a long discussion, but basically whatever you have available is better than nothing. Some people prefer dopamine, other prefer other agents. There is not like some kind of guideline on that. It's more up to the preference of the clinician and whatever he feels more comfortable with. In terms of cardiopulmonary management of these patients, so again, it's extremely important to correct the hypotension as soon as possible. We know that injured nervous tissue is very, very sensitive to hypotension. We know that very well from the traumatic brain injury literature. It's actually one of the few areas that we have a very high level of evidence that hypotension can be very bad for the injured brain, and the same applies for the injured spinal cord. And in general, we need to maintain mean arterial pressures approximately at 85 millimeters of mercury for the first 7 days to make sure that we have adequate perfusion of the spinal cord. That applies especially in cases that we have ongoing spinal cord compression, so we need to make sure that the compressed spinal cord gets adequate perfusion. If we do a good decompression of the spinal cord, there is that rule probably is not as important. And these patients usually use or need an ICU or a monitor bed because the management of their vital signs can be very, very challenging, especially the blood pressure. So how do we examine these patients from a neurological perspective? So we use this ASIA classification, this ASIA neurological exam. And first we examine some key sensory points, and we examine the light touch and the pinprick sensation. And we document which is the most caudal level that has normal sensation. Then we examine the motor strength, and as you know, we examine the motor strength with this scale. And grade 3 means that the patient has anti-gravity movement. Grade 5 means full movement. 0 means no movement at all. So we document which myotome has at least a grade 3 function. And then we determine the neurological level of injury based on which is the most caudal segment that has intact sensation and at least anti-gravity movement. This can get a little bit more complex by documenting the zone of partial preservation, but that's not really, that's probably subject for another talk. And we also need to document whether there is any kind of sacral sparing, and we do that with examining for deep anal pressure and for voluntary anal contraction. If that is present, it means that we have sacral sparing, so this is an incomplete spinal cord injury. If they're absent, then we're dealing with a complete spinal cord injury. You can see here the classification. A is complete. B is that we have some sensory function, but there is no motor function. C is motor incomplete. That doesn't meet the requirements for a D, which is more than half of the key muscles have at least anti-gravity movement. And E is normal. So here is another common mistake. We may have a patient with a spinal fracture, but without spinal cord injury. And then sometimes I say, oh, he's ASIA E normal. That's not really correct. So E is a grade that we place on a patient who had some kind of neurological deficit, and then that deficit fully resolved. So if a patient comes with a spinal fracture and he doesn't have any neurological deficits, he doesn't have spinal cord injury. So this ASIA classification doesn't apply for him because that's only for spinal cord injury. Now, a few things about the anatomy of the spinal cord, just to remind us that the spinal cord does not extend through the whole length of the spine. it terminates around L1. So that's why we have like a T11, for example, fracture there, a neurological deficit. The neurological level might be actually an L2. So that patient might have some hip flexion, although he has like a T11 injury. Another thing is that in terms of the myotomes, there are some muscles that are innervated by some specific nerves. There's kind of selective innervation, and that allows to determine the level of the spinal cord injury. And these are the key muscles that we examined: the biceps for C5, wrist extensor for C6, the triceps for C7, and that's something that usually is done by the neurosurgery team, and all members of our team are well familiar with that anatomy and that neurological examination. So now let's about the dermatomal distribution. So this is a kind of very, very complex, dermatomal distribution. Many people, don't really understand why our bodies have this complex distribution. But if we think about the embryological development of the nervous system, how the lips develop and they grow sideways with the thumb up, so that explains why the C6 nerve root goes to the thumb, the C7 to the middle finger, C8 to the little finger, and something similar applies for the lower extremities. That's why we have like the L5 going a little bit on the dorsal aspect of the foot, and S1 going to more the sole of the foot. It has to do with how the limbs were rotated during the embryological development. So now let's see some incomplete type of spinal cord injuries. So we have that patient, 77 years old, he fell from standing height. His vitals are fine, but he complains that he cannot move his hands. He has almost full strength in his lower extremities. So what do you think is going on with this patient? Does he have some kind of conversion disorder? Does he have bilateral brachial plexus injury? Does he have spinal cord injury in the cervical spine? Or does he have a subdural hematoma? Again, he's from the clinical examination, the main thing is that history of fall and bilateral upper extremity weakness. So let's give a few seconds for the audience to. And this is the question 6. Lindsay, this is question 6, please. Okay. So I think over here we're dealing with a central cord syndrome, so we're dealing with a cervical spinal cord injury. And now let's review some incomplete spinal cord injury syndromes. So the most common is the central cord syndrome, where it's very common in the elderly patients that they have pre-existing stenosis in their cervical spine, and during the fall there is some further compression of the spinal cord, and it's not really clear the pathophysiology of that syndrome, but we think that there is edema that happens in the spinal cord, and the central part of the spinal cord gets affected the most. And this is where the fibers, the pathways, the motor pathways that go to the upper extremities are located. The motor pathways that they carry the fibers for the lower extremities are a little bit more peripherally located, and they're not affected as much. So that's why we see more pronounced weakness in the upper extremities than the lower extremities. In the past, we used to treat that only conservatively, but the current trend is to be a little bit more aggressive with surgical intervention. We don't have any high level of evidence on that, but that's the current trend to operate on these patients. Then we have the anterior cord syndrome, where we have some preserved sensation because we have preserved the dorsal column function. And that's more like a vascular type of injury. It can be spontaneous or can be some kind of vascular etiology, but sometimes we see it after trauma. And the anterior spinal cord injury, which is located over here, perfuses the anterior 2/3 of the spinal cord. So that's why we have this type of neurological deficits. The posterior 1/3 of the spinal cord, and specifically the dorsal columns, are perfused by the posterior spinal arteries, which are not injured in such a setting. It's only the anterior spinal artery. So that's why we have this pattern of neurological deficit. And then we have the Brown-Séquard syndrome, which usually is after a penetrating type of injury. And we have loss of function from one half of the spinal cord, and the other half remains pretty much intact. So what kind of imaging do we get for our spinal cord injured patients? So nowadays we go directly for a CT scan. So if a patient has spine pain, tenderness, pain radiating to extremities, suggesting some kind of radiculopathy, if has any weakness or decreased sensation, then we get a CT scan. We also pretty regularly get a CT scan on patients that we cannot get a reliable exam from. And we also need to remember about the possible need for a CT angiogram for some specific types of cervical spine fractures. Specifically, we have a fracture of the upper cervical spine, if we have a dislocation, or if we have any fracture that they involve the transverse foramen, because this is where the vertebral artery is located. So this fracture, it has a very high chance to have caused injury to the spinal cord, sorry, to the vertebral artery. So here is an example of CTA. You can see on the left side that the vertebral artery is visualized, it is patent, but on the right side we don't see anything over there. So this is an occluded vertebral artery due to the injury. In these cases, we might go for a conventional angiogram to see the pattern of the injury, to see if we can revascularize or if it's some kind of dissection to stent it. But if there is nothing we can fix, then these patients usually need very early on anticoagulation or antiplatelet therapy, because there is a high risk that they might get a brainstem stroke, because the vertebral artery perfuses the brainstem. So if there is a thrombus inside the vertebral artery that travels, then it will cause some kind of stroke in the brainstem, which is very, very bad thing. They're very, very devastating types of strokes. And here is a modern classification of the upper cervical spine injuries. If you go to some especially older books, there are so many classification schemes, and it can get very, very complicated. But nowadays we usually, most of the trauma centers are using the AO spine classification. So that's the classification for the upper cervical spine. And this is a classification for the subaxial injuries. Subaxis is the C2, so these are this is the classification for injuries below C2. I won't go into any more detail about that, but this classification helps us also with selecting which is the best operation for these patients. And an older classification scheme is the SLEEK grading system, which it has many exceptions, and I don't think it's as useful nowadays, but it communicates some very important principles. So when we're evaluating a patient with spinal cord injury, there are three things that we need to keep in mind when we're deciding about further treatment. One is the morphology of the fracture. One is the integrity of the ligaments that keep the bones together. Because one thing that we need to remember here is important, that when bone heals, it forms new bone, and the new bone is as strong as the bone before. But when we are dealing with an injury to the ligaments that holds the bones together, then the ligaments heal by forming scar, and the scar is nowhere as strong as the ligament before. So when we have a disruption of an important ligament of the spine, we usually operate on these patients because we know that the healing is not reliable, and they might develop delayed instability. And of course, the third factor that we carefully consider is the neurological status. So with this classification scheme, you were grading the injury from 0 to 4 for morphology, 0 to 2 for the ligaments, and 0 to 3 for the neurological status. And based on the overall grade, you were deciding whether to go for surgery or not surgery. And over 4, it was operative treatment, less than 4, non-operative, and 4 was kind of, let's say, center of preference. But what you see here is that they were grading the incomplete spinal cord injury as as 3 versus complete as 2. The reason is that an incomplete spinal cord injury has a higher potential for recovery than a complete spinal cord injury. We might need to be more aggressive for an incomplete spinal cord injury. So AO Spine also came up with a classification for thoracolumbar injuries, and it's very, very useful for the selection of the treatment, but that's, again, probably a topic for another discussion. And we also have the TLIX classification, which, again, the same principle as the SLEEK for the cervical spine. It's just a little bit, again, we assess the morphology of the fracture, the integrity of the ligaments, and the neurological status, and we make a decision whether we should do surgery or not. Now let's go, all that applies for the adult population. Let's go now to the pediatric population. So after what age do you think that the spine anatomy in kids is similar to an adult? Is it 2, 6, 8, or 12? Let's give a few seconds. Okay, so the correct answer is 12 years of age. After that age, usually the anatomy that we get on the CT scan is very, very similar to the adult anatomy. For kids younger than that, it requires special experience to read a CT scan. And we can see here some examples why the anatomy is different. So as we know, the bones start growing from some ossification centers, and in kids, there is still some cartilage between the ossification centers, and they're basically these, as we call it, synchondrosis, these lines here. So somebody who is not experienced might read that as some kind of odd fracture, but that's just normal anatomy for kids. Also in kids, the distance between the anterior arch of C1 and the anterior surface of the dens is, it can be up to 5 millimeters. Well, 5 millimeters in adult, that means that there is a rupture of the transverse ligament. It suggests an unstable injury, but in kids, that's normal. Also in kids, we see this old C2, C3 subluxation, that when somebody sees that on an X-ray, he might think that there is significant ligamentous injury on C2, and we have the traumatic spondylolisthesis, but that's normal in kids. And one way to differentiate between pathologic subluxation versus normal or versus pseudo-subluxation is to see where the posterior arch of the lamina is and if they're aligned or not. You can see here C1, C2, C3, they're pretty much aligned. So that's, let's say, that's a tip to differentiate between pseudo-subluxation and real subluxation in kids. And as we said, we immobilize the spine in our spinal cord injury patients. There are several types of equipment that we can use to immobilize the spine: the hard cervical brace, the various types of orthosis that then we have the halo that we put pins in the head. We used to use that much more often in the past. Nowadays, it's very rare to have to use it, but there's still some indications. And we have available, I know for, we had it in Elmhurst, and we have it here available for these rare cases that this type of treatment might be the best option. Usually it's some types of C1 or C2 fractures in younger people that we don't want to fuse them. And these are the type of fractures that might select this type of immobilization, this type of treatment. And we also have the Gardner-Wells traction. We see that the tongs here that we apply to the side of the heads, and we apply the traction through that instrument. Now, a question that frequently comes up is, how about steroids? Shall we give steroids? So there was this big study from 1990 that they claimed that there was some kind of improvement in patients who received high doses of methylprednisolone. And that led to a guideline in 2002 that they were suggesting that steroids would be an option. Then we had another guideline in 2013 that they said, oh, steroids is not recommended, the complications not worth the possible benefit. And then 2017, they said, oh, let's consider again methylprednisolone. And all these guidelines were basically reinterpretations of that initial study. We didn't really have any significant additional evidence to change that. So that shows how much controversy there exists in that field. And my personal take, and I will try to extrapolate some data from the traumatic brain injury, because I think that we can extrapolate some evidence from TBI to spinal cord injury, because we're dealing with injured nervous tissue in both areas. So in traumatic brain injury, we have level 1 evidence, and I think it might be the old level 1 evidence that we have for TBI. that high doses of methylprednisolone is not beneficial for the patient. And in that trial, in the CRASS trial, they used the same high dose of methylprednisolone that they used in that study. Now, having said that, this is about a very, very high dose of steroids. We very frequently use dexamethasone for other pathologies, and we know that it has a very favorable safety profile. So in some trauma centers, we might select to use a low dose of dexamethasone, like probably 10 milligrams bolus, and for a very short period of time to help with the spinal cord edema. That's not unreasonable, and this evidence, these guidelines do not apply for the use of dexamethasone. That I said, we don't really have any high level of evidence for the use of dexamethasone at the doses that I said. So how about spine surgery? So what are the goals when we do spine surgery? So the main goal is to decompress the nervous tissue, and this can be achieved through the reduction of the fractures, through any kind of through removal of any bony fragments, discectomy versus disc herniation, laminectomy, and in some cases we might even open the dura to give more space for the swollen spinal cord. So you see over here, there was a bony fragment in the spinal canal, and after the surgery, the bony fragment was removed, and we also realigned the spine a little bit better over here, as you can see. Another goal of the surgery is to achieve the definitive spine stabilization. As we discussed, any kind of external spine stabilization cannot offer a definitive immobilization. The reason is that there is a lot of soft tissue between the brace and the spine, and that soft tissue allows for some movement. The definitive type of spine stabilization is to do surgery and to place hardware inside, screws, to lock the bones in place. And another goal of surgery is to achieve, to restore normal anatomy. You see here we have a dislocation of C2, and after the surgery we reduced the dislocation. It's not perfect, there's still a few millimeters, but it's perfectly acceptable, and it's the best it could be achieved in that surgery. Sometimes, perfect is not feasible. So how about the timing? When do we operate on these patients? So more than 100 years ago, it was identified that if the pressure of the cord is allowed to remain for many hours, then the damage is irreversible. And more recently, there is a lot of literature that they suggest an ultra-aggressive, let's say, approach to the timing of the surgery, because in the past we used to quote that we need to operate on these patients within 24 hours, but there is, we believe that probably this 24-hour window, it misses the best time window, which probably something shorter than 24 hours. So there is some evidence that probably less than 8 hours, less than 12 hours, and I will go again to the brain literature, the TBI literature, where it has been shown that the time window to evacuate a subdural hematoma is 4 hours. After that, the mortality really goes up, and the outcomes really, get really bad. And that's why the ACS, reviews any subdural hematomas that were operated after 4 hours because of this literature. And actually, from our experience from Elmhurst, where we have been very, very aggressive with the operative treatment of these patients, and we try to get them to the OR as soon as possible, we have some data that if we operate within 4 hours, then these patients might actually do better than patients that were operated after 4 hours. And you see here that we, over here, we group the patients less than 4 hours and 4 to 24 hours, just to exclude any patients that were operated after the 24-hour window, which is the current standard. So there is this, current trend to operate as soon as possible. So again, why? Because the surgery achieves decompression of the spinal cord and also achieves the definitive spine stabilization and prevents any additional injury to the spinal cord. And it's a similar principle to time is brain, time is spinal cord. But we need to be careful about spinal cord injuries that when we're treating spinal fractures, to treat the spinal cord injury, we need special equipment, and we need to make sure that everything is available at the hospital. I know that both in Elmhurst and Morningside, we have all the instrumentation that is needed to perform these surgeries. So that's not an issue, but it might be an issue for other hospital settings. We need to remember that these cases might take long, and they will be, most of these cases are done in the prone position. So if that patient has some kind of additional injury in his chest or his abdomen, the trauma team won't be able to open up the chest or the abdomen, versus when we're doing a craniotomy and there is chest or abdominal pathology. The trauma team can work simultaneously with us and deal with the additional pathology. But that is very, very challenging for spine cases. It's actually almost impossible. When you start the case, you need to finish the case. It will be very difficult to stop in the middle of the case, to flip the patient supine, to do laparotomy. And also these cases might have significant blood loss, so we need to be prepared about that. So let's have an overview of the spinal cord injury management. What are the important principles? We need to remember that we need to maintain good blood pressure for these patients. We need to maintain good oxygenation. We need to make sure that their spines are immobilized to prevent any additional injury, and all that is EMS, ED, trauma. Neurosurgery is not involved yet with the management of these patients, and that also shows, why the management of spinal cord injury is really a team effort. It's not just one service. It's also like a chain. I mean, any break in the links of the chain, would not really, it will lead to very bad outcomes. So the roles of everybody are very, very important. And then we have the decompression of the nervous tissue and the definitive stabilization that usually is achieved through surgery. And then these patients need a specialized rehabilitation. We're fortunate to have at Mount Sinai a spinal cord injury rehabilitation model system, and they do an excellent job, and we're very, very fortunate to have that. And as you can see, optimal outcome gets very close to the Mount Sinai logo. They're connected. So how about the prognosis? What are the factors that determine the prognosis in spinal cord injury? The most important is the age of the patient and the ASIA classification as ASIA A, B, C, D, or if it is C, then it means that everything has resolved. In terms of imaging, we use the basic score, which in an axial view of the MRI, we assess the degree of edema. And also on a sagittal view, we determine the length of the injury, how many levels the spinal cord edema extends. There are some other biomarkers or motor evoked potential. These are more like research, but they carry the potential of being more useful in the future. Now, how about complications? Although I have only one slide, but that's a very, very important slide because these patients are prone to many types of complications, and some of these complications can be even life-threatening. So they are these patients, they can develop very easily joint contractures, and early physical therapy and early rehabilitation medicine consultation is very, very important. These patients might develop permanent hypotension, and the oral agent midodrine can be very helpful. And that usually allows us to take them off the IV pressures. They might have bradycardia, and there are various agents that we can use. Remember that especially the acute phase, for example, when we're suctioning, they might develop reflexive bradycardia, and in this case, we might have to pre-treat them with atropine before we do the suctioning if we identify an association between bradycardia and a specific maneuver that we do. Later on in the subacute phase, they might develop autonomic dysreflexion, and it's a very, very impressive. They become very, very hypertensive, headache, fever, flushing, and usually what causes that is some kind of noxious stimulus, which could be something similar like bladder distension. This can be very, very annoying and even dangerous if the hypertension is really high. These patients are also prone to develop respiratory complications, and early chest physical therapy, airway suctioning are very, very important. And for patients with high cervical injuries that they don't have, they have loss of innervation of the respiratory muscles, then we might select mechanical ventilation or stimulation of the phrenic nerve, or might have to do tracheostomy to prevent respiratory complications for these patients. These patients are also at risk for peripheral ulcers. Also, the urinary management and the bladder and bowel management can also be very, very challenging in these patients. And initially, we treat them with Foley, and then we go to intermittent catheterization to minimize the risk for UTIs. And they can have very serious bowel problems, and we need to remember to place them on a bowel regimen and keep track on whether they have bowel movements or not. There are some additional delayed complications that this patient can have. One of the most fearsome is cergomyelia, which is very, very challenging to treat. And cergomyelia has to do with accumulation of CSF inside the spinal cord. The pathophysiology is not well understood, and in regards to the treatment, it's surgical treatment, but we really don't have like a very good option. There are various options, but they all come with significant disadvantages. And usually what we do when we decide to treat that surgically is we detether the spinal cord, and we place some kind of catheter to drain the syrinx cavity. What I prefer is pseudopleural stent, where we put a catheter that starts from the syrinx cavity and ends up in the pleural cavity. Another delayed complication is spinal instability. So we see this patient with a type 2 dense fracture. We treated that with a brace, as you can see here, and the alignment was good. But when we saw that patient in the follow-up, he had developed a retrolisthesis. So you see here the anterior surface of C2, and there is a big step off over here. Compare this area here and this area here. So this patient had delayed instability. So we had to do surgery on him to fix that. Another issue is retained bullet fragments. Usually when we see a bullet inside the spinal cord, we remove it. We might not do that in the acute phase, but we try to do that in the subacute phase. The reason is that most bullets contain lead. As you can see here, there's a brass jacket, and inside there's lead. So these bullets usually, surrounded by CSF, and then the lead can start spreading in the central nervous system and can cause delayed lead toxicity, which can present as late as 40 years later. So when I see that, especially in younger patients, then I usually offer removal of the bullet fragment to prevent that condition, which can be very, very challenging, because the diagnosis can be very, very tricky, because it might present with a cognitive decline over years that might not be, there might be a delay in identifying that. And the treatment is not really, we don't have an easy treatment. If that happens, they need to get IV agents. And even if we do that, there is still a lot of lead that has been absorbed by the bone, so they need like a lifelong therapy to treat the lead toxicity. So why risk that when we can do a single surgery and remove the bullet? And that's usually what we offer to our younger patients who have retained bullet fragments in the spinal canal. There are some newer concepts on how to treat spinal cord injury. One of them is to CSF diversion. It's similar to placing an EVD when we're dealing with a TBI. There are some other principles. One of them is hypothermia, but we don't have any evidence that it helps. It increases the complications without really helping that much. The ideal would be to, induce some kind of local hypothermia in the area of the injured spinal cord, but not induce systemic hypothermia, which is associated with complications. And that can be, it's not feasible at this moment. There are some newer techniques to treat spinal cord injury. One of them is to implant scaffolds in the area of the spinal cord injury. And actually we have a clinical trial active at both Morningside and Elmhurst Hospital. And we haven't been able to enroll any patients because they have very strict inclusion criteria, Asia A, T2 to T12, but they have some additional criteria about the injury severity scale. And basically, if a patient has multiple additional injuries, he or she is not a candidate for that study. So although we have this clinical trial active, we haven't been able to enroll patients, but if you have any patients with a complete spinal cord injury from T2 to T12, please reach out to us because that patient might be a candidate for that study. There are some other principles, the use of stem cells or neurotrophic factors, although we have them, here differently, but in different classifications. But actually, we believe that a mechanism of function of the stem cells is through the secretion of neurotrophic factors. So we have them here separate, but probably they're not distinct entities. There's a lot of overlap. We also have the option of spinal cord stimulation. There has been some literature recently about that, and they have published some very encouraging results. And although this is not standard of care yet, but that's something that I always mention to the spinal cord injury patients, especially the acute phase when when you tell a patient he or she is paralyzed and that we don't have any treatment to reverse that, it's very easy for that patient to go into depression. And what I tell them is that, look, this is what the standard of care for 2020. We don't know next year whether we're going to have some kind of effective treatment. So you need to remain healthy, you need to remain in good spirits because we might come up with something good in the following years. And so remember to maintain the hope in these patients, very, very important. And in the past, we used to consider spinal cord as just a nerve. Then we realized that it is the center for some reflexes. But more recently, we actually have realized that it's actually a computational node. And also, we believe that the spinal cord participates in the plasticity of the central nervous system. And there have been many studies that they have showed changes in the brain after spinal cord injury. So spinal cord is definitely very, very important, and it has many functions that they're not very well understood yet. So yeah, that's it, and we're open for any questions. So we got very close to 8. The presentation ended up being a little bit longer than expected. But if you have any questions or any comments, please.
You can put them up in the chat.
That was a great talk, Dr. Margetis. Thank you very much. Yeah, if anybody has any questions, by all means, you can unmute yourself and ask away or ask in the chat. I was wondering, Dr. Margetis, since you have worn 2 hats in terms of both spine surgery and being fellowship trained in pediatric neurosurgery, if you could maybe give the group a very brief synopsis of the key differences in spine trauma in pediatric patients compared to adults. I know it's a rather large topic, but maybe.
Yeah, so an important difference, and I didn't mention that here, is that in kids we might have spinal cord injury without radiological abnormalities. That was an entity that was more common before the MRI era. There were many, especially kids with a normal CT scan, and they had a spinal cord injury. But in the MRI era, when we get an MRI, we usually are able to see ligamentous injury, but there are some cases that you might have a normal MRI and still have a patient with neurological deficits after some kind of accident that we believe that are coming from the spinal cord, but we cannot really see any abnormality even on the MRI. And the reason for that, we believe it has to do with the fact that in kids, the ligaments that hold the spine together, they have some laxity, they have some elasticity. So probably at the moment of the injury, there was like increasing the length of all the ligaments of the spine. There was an elongation of the spine. But we know that the spinal cord doesn't have any elasticity. So there was probably an elongation of the spine without any kind of focal injury to the ligaments or the bones of the spine. But that elongation stretched the spinal cord and it caused the spinal cord injury in kids. So that's a big difference. We don't really see that in adults. In adults, when we get an MRI, most of the times we're able to identify the spinal cord injury and the injury to the ligaments or the bones of the spine that led to that spinal cord injury. So that's a big difference. Also in kids, we see a very bad pathology, the cranial dislocation between the occiput and C1, and that has to do with the fact that the kids have big heads, bigger heads in relation to the spine, so they can suffer that devastating injury, which is actually fatal most of the times. So these are, I would say, two big differences between adult and pediatric population.
I have a quick question. Con, was a very nice talk, very comprehensive. One question about the timing for surgery. You think that this early decompression, early surgical treatment, or ultra early, as you said, is the same across all Asia scores, or Asia A or Asia B is more compelling to perform earlier surgery than, let's say, Asia E?
Mm-hmm. So, they believe that, complete spinal cord injuries have less potential for recovery. But unless I see a transection of the spinal cord on the MRI, honestly, I try to be aggressive even with complete spinal cord injuries because sometimes you have the spinal shock, so meaning that you don't see any function, but that doesn't mean that there's some kind of irreversible injury to the spinal cord. It might be just the contusion and the concussion, let's say, of the spinal cord that you don't see any movement. So if you decompress early, you might restore some function. So I try to be aggressive with the timing in all cases, with the only possible exception, again, if we see a transection of the spinal cord where we know that we cannot fix that.
Hey, Con, this is Ray Wedderburn from Trauma. Just wanted to say thank you again for and thanks Zachary for organizing this conference. I think this is a great idea. I mean, obviously, trauma is a team sport. It's multidisciplinary, and I think this is sort of a great adjunct to some of the things that we've been doing, and looking forward to further sessions. Thank you.
Great, thanks for attending. If there were a couple questions about whether or not the PowerPoint slides and video will be available, so we're going to try and set up it so that the recordings are online as well as the PowerPoint slides. And once we have that set up, we'll share the link with everybody. But the goal will be to kind of house a repository of these so people can reference them later on. As well, for the next meeting in October, we'll probably have a webinar registration process so that it can track attendance kind of automatically, and we should have CME approval by that time so that people that attend will be able to claim 1 hour of CME for each of the conferences. And if anybody has any suggestions of topics or speakers or wants to volunteer, just get a hold of myself, Zachary Hickman, or Dr. Margetis or Dr. Dangiach, and we'd be happy to either have you speak or reach out to whoever you think might be a good speaker or present on a topic that is of interest to everybody. So thanks everybody for attending. Thank you, Dr. Margetis, for a great talk, and we'll see everybody in October, I hope.
Thank you very much.
Thank you.
Thank you.